Welcome to the ASCO eLearning Weekly Podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complimentary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Hello, my name is Komal Jhaveri, and I'm a breast medical oncologist with dual appointments within the breast medicine and early drug development services at Memorial Sloan Kettering Cancer Center in New York. Today, we compare two patient cases that relate to the use of adjuvant treatment for breast cancer. These two cases have similarities, yet the recommended treatments may be different. Let's look at these cases. Our first patient case is Jennifer. Jennifer is a 48-year-old woman with stage 2A invasive ductal carcinoma. The size of the tumor is 2.2 centimeters and it is grade 3, node negative, ER positive, PR positive, and HER2 negative breast cancer. Her recurrence score on the 21-gene Oncotype DX assay is 22, which indicates intermediate risk. Jennifer underwent a lumpectomy with sentinel lymph node dissection and will also undergo adjuvant radiation. Her choices for systemic therapy include chemotherapy plus endocrine therapy or endocrine therapy alone. We will discuss this right answer and the rationale for this treatment choice after we discuss our second patient, Susan. Susan is also a 48-year-old woman with grade 3, ER positive, PR positive, HER2 negative breast cancer. She also underwent a lumpectomy and sentinel lymph node biopsy, which revealed a stage 2B invasive ductal carcinoma with 1 out of 2 lymph nodes measuring 0.5 centimeters with no extranodal extension. The size of the tumor is 2.2 centimeters, the same as Jennifer in case 1. In Susan's case, the Amsterdam 70-gene mammoprint assay deemed her to have low risk of recurrence. Her choices for systemic therapy include chemotherapy plus endocrine therapy or endocrine therapy alone. Now, as you can see, both cases have some similarities, but there are some differences. Would these differences lead your choice of treatment in a different direction, or would both patients receive the same treatment? If treatment is different, what is the difference that changes your choice of treatment? As way of background, the standard treatment for hormone receptor positive, HER2 negative, early stage node negative breast cancer is surgery followed by endocrine therapy. Since the early 2000s, adjuvant chemotherapy has been recommended to most of these women, but the added benefit from chemotherapy is modest for most. Identifying patients with a high risk of recurrence and selecting optimal therapy for an individual patient while avoiding overtreatment is critical for decision-making on adjuvant therapy. Many different gene expression assays are now available and have helped identify cancers that are at a low risk of recurrence, such that the addition of chemotherapy would not provide a meaningful improvement in outcome. ASCO supports the use of many of these assays, including but not limited to the 21-gene expression Oncotype DX assay, the 70-gene mammoprint assay, among others. However, an important unanswered question remains whether these assays can reliably identify tumors that are insensitive to chemotherapy, even if the risk of recurrence based on the clinical pathologic factors is sufficient to consider adjuvant chemotherapy. It is now known that the cohort of women with low recurrence scores on the TAILOR-RX trial have an excellent survival and do very well with adjuvant endocrine therapy alone. And while the outcomes among patients with high recurrence scores from the TAILOR-RX study have not been reported yet, given the improvements in breast cancer mortality on the order of 20 to 30% in unselected patients, we do treat this higher risk patients with chemotherapy and adjuvant hormone therapy. It is important to remember that the TAILOR-RX study was mainly designed, however, to evaluate the best treatment for women with intermediate recurrence scores, defined in this trial as between 11 to 25. This is particularly important because most patients, approximately 70%, fall in this intermediate risk category. Based on the recently reported results, endocrine therapy was non-inferior to chemo plus endocrine therapy in women with intermediate scores of 11 to 25. However, in an exploratory subgroup analysis, the benefit from adjuvant chemotherapy differed for women younger than 50, or premenopausal women, compared to women older than 50 or postmenopausal women. Specifically, among women younger than 50, chemotherapy plus hormone therapy was associated with a lower rate of distant recurrence at 9 years compared to hormone therapy alone. It is certainly plausible that chemotherapy-induced menopause could have contributed to this observed benefit, as this TAILOR-RX trial predated the soft and text studies that have since demonstrated the benefit of ovarian suppression in premenopausal women. Clinical parameters and molecular features together can further improve the accuracy of prognostic estimates. For example, the Recurrence Score Pathology Clinical, or RSPC, that includes recurrence score, age, tumor size, grade, type of hormone therapy, provides a significantly improved prognostic value over the recurrence score alone. Now, in the MIND-ACT, which is the microarray in node-negative and 1 to 3 positive nodes disease trial, the investigators utilized an online tool, Adjuvant Online, to determine the clinical risk for an individual patient, and genomic risk was determined using the 70-gene MammaPrint assay. The trial specifically investigated if the 70-gene signature can enable patients and clinicians to avoid standard chemotherapy in a single discordant subgroup of patients, namely those with clinically high risk, for whom standard adjuvant chemotherapy would be advised, but the 70-gene signature identified low risk. Notably, 48% of the patients included in this trial had 1 to 3 positive nodes, and 93% had grade 2 to 3 tumors. The investigators asked whether this group would have the 5-year rate of metastases-free survival of more than 92%, which was identified as the cutoff for benefit for chemotherapy. In this group at 5 years, the 5-year rate of survival-free distant metastases was 94.7%. So the immediate next question was whether withholding chemotherapy in such patients is then safe. The results indicated a survival advantage of 1.5 percentage points for patients who underwent chemotherapy. However, this analysis was statistically underpowered. So both our cases have similarities. They're both premenopausal with similar tumor size and grade. Both were determined to have either intermediate or low risk of distant recurrence using Oncotype DX and MammaPrint assays respectively. But there are two main differences between the characteristics of these two cases: lymph node positivity and genomic risk scores. For case 1, you will recall Jennifer is under 50 years of age with a 2.2 centimeter grade 3 tumor and a high intermediate recurrence score. It is important to highlight that the median tumor size for the patients enrolled on the TAILOR-RX trial was 1.5 centimeters, and 86% had low to intermediate grade. Additionally, among women younger than 50, chemotherapy plus hormone therapy was associated with a lower rate of distant recurrence at 9 years compared to hormone therapy alone if the recurrence scores were more than 15 in the TAILOR-RX trial. At 9 years, the absolute percentage point difference was 1.6 for recurrence scores between 16 to 20 and 6.5 for recurrence scores between 21 to 25, although the rates of overall survival were similar. The tools to integrate clinical features with Oncotype assay are readily available, and clinicians may wish to consider using them routinely. The 10-year risk of distant recurrence based on RSPC, or Recurrence Score Pathology Clinical, was calculated for Jennifer as 23%. And Jennifer was treated with a combination of endocrine therapy and chemotherapy. For case 2, you will recall that Susan has grade 3 node-positive disease, but with a low 70 gene signature risk, suggesting that any plausible benefit from chemotherapy would be modest. However, a difference of 1.5 percentage points might mean more to one patient than to another, and the treatment approach can also be variable among experts. We all eagerly await further data from the randomized trials such as RxPonder to further inform our approach in node-positive breast cancer. After expressing understanding of the risks and benefits of chemotherapy and the data from the MINDAC trial, Susan chose to be treated with a combination of endocrine therapy and chemotherapy. Thank you for listening to this week's episode of the ASCO e-Learning Weekly Podcast. For more information on the adjuvant treatment of breast cancer, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive e-Learning Center at elearning.asco.org.
Thank you for listening to this week's episode of the ASCO e-Learning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive e-Learning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.